Hello, my name is James Klim. How are you folks doing on this 4th of July weekend? I'm going solo tonight, but maybe I'm watching to make sure we can maybe tune into Todd. He's doing something really special today. But today's topic, we'll get to it in just a moment with Todd, but today's topic is on microocclusion in the CAD/CAM clinical theater. And I use CEREC, I use the Primescan, I've used OmniCam, I use the Blue Cam, I use the Red Cam. And all these systems have worked well. The Prime has never been better. I tell you, through all those hardware processes through the years, we had to work each one. Even with Red Cam, I did well, but I had to work the system a lot more. But we're really doing well, particularly with occlusion. In fact, one of the major reasons why I like Primescan and the accuracy is for managing my occlusion, and we're going to get into that. But let's see if I can get Todd on location right now, because I know he's out there. You know, has many hobbies. He's a great astrophotographer, and now he's into racing bikes with his new bike, and he just sent me this picture today, and we're going to go out on location with Todd. But before we do that, if you have your sunglasses nearby, make sure you put them on, because this is going to be kind of exciting.
James Klim, sorry I couldn't join you tonight, but I had to come to Circuit of the Americas, one of the most world famous racetracks, and I'm doing my very first track day. And you know how much I'd rather be with you tonight. You're my good friend, but you know I'd rather do this. I just got my brand new Ducati. And 4th of July weekend, 2 days at Circuit of the Americas. Couldn't possibly have a better weekend. Hey, I know you're talking about something fun like occlusion. Well, I'll keep it simple, because I know you're going into great depths. I keep it real. Like, I don't want to get too detailed in all of the different religions of occlusion, let's call it. Let's say there's East Coast and West Coast occlusion. I just think there's an envelope of occlusion, meaning we can all tolerate different things, and it's our role as clinicians to find what that is. And so one of my big pet peeves in occlusion, I got just a couple more minutes, I'm getting waved off here. One of my big pet peeves in occlusion, let's call it, is you come in for a new patient exam and somebody's instantly grinding you down and adjusting, and you know, those are wear patterns that possibly have lasted for years and years and years. And so I am very judicious when it comes to adjustments and things like that. I always tell the patients that, you know, it's good to stop. We can always do a little bit more, and I set them up to do multiple visits. So when it comes to occlusal adjustments, I think it's our role to find the envelope of the patient. Now, as far as CAD/CAM dentistry goes, we need to obviously dial in the occlusion. And I'm going to give everybody out there a real big pearl out in the CEREC world. The biogeneric calculation, it's awesome, man. We get some great detail, but it always is too small, always. So start doing a pre-operative biocopy folder. You don't even have to use biocopy. Just make sure you have it, because you're going to see that the biocopy or the original condition is typically larger. But the other thing you get a lot of advantage out of that is that you get to see the wear patterns of what they had before. So if you're just playing colors in the software, green, teal, light blue, then all you're doing is making it so that they have pinpoint occlusion. Let's say that's tooth number 19. If I got pinpoint occlusion on tooth number 19, but I have big, huge wear patterns on the adjacent teeth, to the human that may feel like they're not touching. So you at least have to analyze what they were before, and what better than to take the biocopy preoperative condition. James, that's all I got to say about occlusion. Love you, buddy. Love your new setup. And be happy for me at Circuit of the Americas. See ya. Peace.
Thanks, Todd. Be safe out there. Always exciting to see you doing your passion, and we should all be doing our passions, particularly in our clinical theater. Occlusion is one of mine. Now, today I'm going to talk about microocclusion. There's this macroocclusion we deal with, which is a broader concept, particularly if we're rebuilding a mouth or setting a new bite. That goes way beyond today's discussion, but microocclusion can be applied to one tooth or multiple teeth. And it's been a focus of mine, particularly with CEREC. One reason why I like CEREC is because I can place where I want my occlusal contacts on that tooth or multiple teeth, and it does really make a difference. Now, you'll see that Todd and I maybe see things a little different, but I think we're both within that envelope of occlusion. I think biocopy is a really important catalog. Now, quite often, posteriorly, I use biogeneric individual, but I always take a pre-existing catalog. So once I'm in my acquisition screen, I'll turn on acquisition in that screen on the right side, and then turn on biocopy, and then take your lower or upper quadrant, whichever your tooth is going to be in, and then copy that over to the biocopy catalog. That will always be available for pre-records, and then when you're designing, particularly on the upper buccal corridors, it will assist in setting up your case. But let's get to microocclusion. I want to share some concepts that I heard at the AACD in, I believe it was 2010, and it was from a lab technician who taught with Jimmy Eubanks, who I have followed for quite a long time. And what we found out is that there's different factors that have an impact on our occlusion. So I'm going to go back to the point one here, and that is preparation, particularly if you're dealing with all ceramic dentistry, the preparation style. And Todd made a comment of this last week. The internal form of your ceramic should be very smooth. That's where cracks can happen, particularly with CAD CAM. The larger burr we mill with, we can get potholes inside of that restoration, and that can lead to fractures. So rounding those line angles from the occlusion to the actual surface is really important. So prep design is very important, particularly for ceramics. Not as important for zirconia, because we have the needle burr we can mill out with. We can go a little sharper with those line angles, but we still want rounded line angles. The occlusal table is real important to remember. As we get older, the occlusal table becomes broader. I know that in my own mouth. So wear and tear, the occlusal table becomes larger. So think of this. If you reflect back to the denture days before we had implants, and that's where I started with, the upper jaw shrinks, so the upper jaw becomes smaller with denture wear over time, and the lower jaw becomes larger with denture wear over time. That's kind of a similar concept. So on the lower jaw, the buccal cusps are your primary working cusps. So as they wear down and the upper lingual cusps wear, there'll be a tendency for that lower jaw to be shoved back. So that means that the jaw joint is being reduced and it's going posterior in the socket. Now that I have studied 3D for quite a few years now, I have seen that. A lot of our patients will tolerate that, but it's real important to look at the occlusal table when we're working with our occlusion. So one thing I like about the biogeneric software is that it's true. Todd said that sometimes and quite often the proposal is a little more petite than the biocopy, particularly if the biocopy has a lot of wear on that tooth. So placing that cusp, the working cusp, and the size of those cusps is really important. This is the very reason why I like biogeneric individual, because we can place those cusps to the opposing marginal ridge and mid portion of that opposing tooth and decrease our working interferences, particularly in function. And that's why I like biogeneric individual so well. There are deflective zones to consider, particularly on marginal ridges. I'd like to get a marginal ridge contact, whether it be one or two, but the important thing within the software is we want to round those marginal ridges, because a rounded marginal ridge will deflect force, whereas a flat marginal ridge will absorb more force, and then it can also be traumatic to that marginal ridge if it is a ceramic. Landing pads, those are the contacts in the fossa, particularly on molars. I want those on flat surfaces. Now, on this tooth, we see quite a few contacts. I usually don't go for that, 6 contacts on a molar. I'm going to go for at least 2 to 3. But the concept here is that I want my contacts on non-inclined planes that will improve our functionality of that tooth, particularly as it settles after the restoration is placed. Even if it's in occlusal contact, there's micro-settling. Morphology really counts, and that's one reason why I like biogeneric individual. That's why I usually don't go for biocopy in an aged mouth, because that is going to be more of a potential traumatic occlusion, and I do want to pay attention to that. So these are the important concepts that I look at when I'm working through occlusion. I'm going to show you 2 videos from my Klim Institute online CEREC teaching site that deals with this concept of occlusion, and then we'll wrap it up. I know today is a holiday weekend. A lot of people aren't available to watch today, but we made this video because we know there's going to be quite a few reruns. So let's go ahead with the first video, which talks about occlusal reduction and preparation and the important aspects of setting that occlusion up through the preparation. One of the secrets to making the software really flow is how we prepare. And more of it is about occlusal reduction. If we have enough occlusal reduction for the material we're using, the software really proposes very, very well when you're using biogeneric individual. I can't overemphasize that. And I've been practicing dentistry for 36 years, and 3 years prior to that, I was in dental school. So that's 39 years of prepping, and I still occasionally have to go back and add more reduction to the occlusal table of my preps. One thing I like about the Primescan and CEREC is that once I'm in that design screen with the cursor details, I will see fairly quickly whether I have enough reduction. If I don't have enough reduction, I don't spend a lot of time with my tools trying to create a thicker occlusal table, because the proposing of this biogeneric individual is profound. I'm all about morphology so we can control the occlusal surface to get optimal function and decrease the lateral forces when that patient is functioning on the restoration that we're creating. And the way you start that process is to get enough reduction. So if we need more reduction, just go back and reduce that area on the prep that you need. And now with the auto cutout feature, go back to the acquisition screen, scan over that prep again, and it will gather that new information so we have enough occlusal thickness on our material. Now, the other thing I want to make a point of here is that you need to know the material you're going to use before you start prepping. And you'll see this formula, right? What does that formula say? It may seem like a lot of reduction, but it's really not. It's minimal thickness recommendations by the manufacturer times 2 to 2.5. Right? And quite often when we're reducing, we reduce for the final morphology. It may not be the condition of that existing tooth if it's already flat and it doesn't fit the morphological flow of the curve of Spee and Wilson for that arch. So it's real important to know that I spend as much time on my occlusal reduction as I do any other surface on that tooth. And we strategically shape it similar to the flow of the occlusal table that we want for that final restoration. Spend the time doing the reduction. Now, I work with Meisinger, and we have what we call the JKO 2 prep kit, and that's my standard kit for most of my preparations in the mouth. And you'll see a link of that below in this video, or you can go to the Meisinger website and just type in the JKO 2 kit and it will have it there for you. I want to prep, I want to be proficient. The other thing I want to know when I'm prepping is what type of margin style is in the best interest of that patient. If they already have a lot of recession, I'm probably going to use zirconia on a posterior tooth, and I'll use 3Y strength zirconia so I can use more of a feather margin. I think about these things before I start because I have to set the case up right. I like lithium disilicate. I've used DMAX for years. That is my go-to restorative material when I'm prepping onlays or more conservative type of preps. Quite often posteriorly, if I don't have the room, I'm going to go over to zirconia. And we need to know the various brands and whether they're a 3Y, 4Y, or 5Y strength factor, because it will dictate how you prepare. Fortunately, the manufacturer will provide for us their recommendation for prep style. Pay attention to it, because the most important thing in prepping the longevity of your restoration is occlusion reduction. It's not as dependent on axial reduction as we see occlusion, even though you want to appropriately prepare axial for your material. Look at that occlusion, because that's really critical. The other way to make your software design flow go well is make sure you adjust the adjacent proximal contacts to the tooth you're working on if they need to be adjusted. That's how you control your interproximal footprint. That's how you control your interproximal embrasures. There's an occlusal embrasure. That's really important, because that interproximal contact should start from 1 millimeter from the height of that marginal ridge in ideal form and function, because that will provide a morphological shape so forces are deflective where they're absorbed within the material that you're placing and the support structure that it's on, whether it be an implant or tooth. The other thing I want to do is control that interproximal contact, so in most cases, unless they're really matured with recession, we can place the cervical portion of that contact 4.5 millimeters from the bone, and with the Call effect, we'll get healthy papillae form, which decreases buccal lingual fluid impacting later on in life. So those two prep things are so critical to optimizing your software flow, cutting down your software design, also in seeding your final restoration. So that is step one. Step one is having enough occlusal reduction for the material you're going to use, because that makes a difference on the proposal. In order to get good cusp-fossa relationship to the opposing dentition, which the software does extremely well with biogeneric individual, we need enough reduction. I can't overemphasize that. Then that sets our design sequence up for success. Now, the next video that is on my online site that I want to share with you is a process of the workflow for a bread and butter posterior restoration design sequence. This is the order that I go in all the time. I talk about the tools and the concepts of setting that occlusion up, so it's always a win-win for you. So let's go ahead and get started with that next video. When I'm in the design screen, there's a sequence that I go through to create a nice smooth flow, so we don't have to spend a lot of time fiddling with our design. There's two things that help us not to fiddle, right? And that's occlusal reduction, get the adequate occlusal reduction, and number two, shape the teeth next door if you need to create the ideal interproximal footprint. When you do that with this system, it's pretty smooth, particularly on a lower restoration. Now on an upper restoration, I'm going to check the buccal corridors and also the height of those buccal cusps to make sure it fits that secondary smile plane. But in most cases, this is my design flow. I want to know what my parameters are. They're really important to get on. I'm going to make sure I have the proper spacer. I'm going to default at 120. There's other parameters that are important to the final outcome. I want to make sure that I have my occlusal contact strength at -50 and my interproximal contact strength is -25. Then the minimal thickness should reflect the materials you're using. My marginal thickness parameter should be calibrated to the following factors: the material I'm using, the speed that I'm milling at. I almost never use a fast mill unless it's on a polymer. But if I'm using a ceramic, I need to know what ceramic I'm using, and usually that's going to be fine mill speed. I very rarely use the left S step burr. It's usually the 12 step burr that will provide a much cleaner mill internally and on that margin. And if I'm prepping really thin feather margins, I'm going to use the extra fine burr system. That's the EF burr system, where the initial mill is with your normal step burr and right cone burr, and then it shifts over automatically on the second set of engines for that fine mill. I call that a pressable mill, and that's how I can do really thin veneers clear down to 200 microns, no chipping. That's another conversation, but the capability of this system with the M6L at this time is phenomenal. Now for zirconia, I definitely love my dry mill with my carbide burrs. When that's happening, those margins are beautiful, so I love my dry mill, and that's how I get great margins without any micro chipping. So you have to think about it, because if you're seeing micro chipping, something's off, either in the calibration of your milling unit, or maybe your burrs are not in the best shape, and you have to pay attention to the material, the marginal thickness, and the speed that you're milling out. There's other videos on this site that will go through that, but I had to make a point of it. But you want to think about that before you design. So when I'm in my design screen, my main two tools would be the form tools. That's add, smooth, and remove, right? And then I'm going to use my shape circular two-directional tool. That works really well for moving the virtual surface around without losing the morphology, which is really critical. There's two other tools I'm going to mention. They are the biogeneric variation tool. That's the very first tool I use if I want to change the morphological shape of the initial proposal. And it's like having hundreds of waxers at your beck and call. All you do is scroll that bar and you'll see different proposal options. You release the mouse on the one you want and you get a new proposal. The other tool I'm going to use is the contact adjusting tool. So that happens later on into the design, and I'll get to that in a moment. So here is my design sequence. Posteriorly, there's a different approach I use for anterior teeth. Number one is I want to make sure that restoration fits the arch. On the upper arch, the buccal corridor and the length of those buccal cusps are important to fit that secondary smile plane. On the lower and the upper, I want to make sure my curve of Wilson and Spee is on. In most cases, that is set up by your model axis. So that's the first thing you check and make sure the proximal contacts are closed. The second step in my design flow is finish the occlusal table. Now, this is a biggie because earlier in a prior video, I talked about some secrets that I do to make sure I don't have to adjust occlusion. Number one is the compression bite, making sure you have enough reduction, right? That compression bite's critical. This is where the bite becomes very critical, so I don't get post-treatment sensitivity and I don't have to adjust my occlusion in. I want my occlusal contacts to be on non-inclined slopes, right? So on a molar, it's usually 3 to 4 contacts, and I want them to be 1 millimeter square. So let's go through that together. So here's a case where we're designing and we're going to pull up the occlusion so we see the contacts in these strategic zones that we want them. Now on a lower first molar, I want 2 buccal cusp, working cusp contacts. Sometimes I'll use a fossa contact there in the middle of the tooth and then a marginal ridge. So what we're going to do is use either the form or two-directional circular tool to pull up the colors where we want them, and then we're going to go into adjust contact feature for occlusion, which is set at -50. That's one of the parameters that's really important to get your occlusion on, and we're going to adjust the occlusion. Now when we see that occlusion virtually adjusted, we're not done. When that aqua color is wrapping over those working areas on a working cusp or on a marginal ridge, that is microlateral or working interferences, because remember that periodontal ligament is moving. So when we're adjusting those contacts, we want to take our removal tool at 10%. So let's say that again. Removal tool, not smooth tool, right? Smooth tool will have a tendency to smooth out a convex surface, but I want to maintain that beautiful biogeneric feature of the software. So we're going to use the removal tool at 10% with a small paintbrush size, and we're going to carve around that aqua feature so the contact is 1 millimeter square on the top of the cusp on a flat surface of a landing pad, which would be in the central fossa. So the way we make that a flat surface is you remove above the contact on that triangular ridge, so that becomes a flat surface. And then on the marginal ridge, we want that to be at the height of the marginal ridge on a flat surface. So when that patient's moving, they're more than likely not going to catch a slide, which would be a bouncing or working interference. So why is all this so important? I know I'm getting a little picky here. I want to avoid post-treatment sensitivity, which happens when a crown or restoration settles after a period of time. Teeth always settle. I've learned that post-orthodontically. I've learned that post-full mouth reconstruction. Teeth will settle. There's little micro motions with that PDL and the various forces from the tongue and the cheek and the function and how they swallow and how the teeth come together, where there's a micro settling process that happens. If I have these contacts in really ideal strategic zones, when that tooth settles, there's a low, hear me out, operatively, there's a really low probability of catching a lateral or working interference, and therefore we lower that probability of seeing post-treatment sensitivity. That's the magic of how this works. So you have to think of this as an engineer, understanding your material and understand how the mouth and forces work, because teeth are always moving around because they have a PDL, unless it's on an implant or ankylosed teeth. So I can't overemphasize this strategic strategy when we're designing our occlusion. Are you okay with this? I'm getting so pumped about thinking about this. Since using this strategy, it's really minimized my post-treatment sensitivity. Hey, we're practicing, we're working in a real environment, and everybody's different. All our patients are different. So there's always a follow-up that we have to do, particularly if we're doing multiple teeth. But for that single tooth, or even when I'm doing full mouth rehabs, this is the strategy I use on a single tooth within multiple teeth, right? It's this simple. The other thing I'm going to look for is the proximal contacts. Now, in most cases, we set that up by how we prepared the teeth next door when needed, right? So when you see that proximal contact, there's several things I want to establish on it. Number one, I want the occlusal side of that interproximal contact to be about 1 millimeter from the height of that marginal ridge. And when that marginal ridge is rounded and you have a contact on it and it's conical, it will have a tendency to deflect that force. As a result, you have a more proficient force dynamic on the material and the tooth or implant you're designing. So that's really important to know. Now, cervically, I want that cervical contact to start 4.5 millimeters from the bone, so we get full papillae fill using the Call effect, particularly if there's granulation tissue that we have to remove because the prior restoration in perio was just not healthy. Now, on the really matured mouth with a lot of recession, you may not be able to get this principle. But in general, this is one reason why I love CEREC and the Primescan, because the Primescan effectively scans interproximal undercut data surfaces on the teeth next to the prep. And that's why it's so important to have that in your scan. So when you're designing, you can look interproximally, just make your model slightly translucent, and you can see interproximal where that cervical side on the adjacent teeth you're designing the contact to, you can see where that is and adjust accordingly, so when you go to seat that restoration, it doesn't bind. Because most restorations, when we're seating, they're going to bind in the cervical side of the contact, usually not the occlusal side. And if the occlusal side's a little strong, it's just going to wedge the teeth apart. Whereas if it's in the cervical side of the contact, it's just not going to go down, and then you have to adjust it. So when you do need to adjust to get a restoration down, you go to the cervical side, right? An effective way to recalibrate those interproximal contacts, if you need to broaden them, is to use the mesial or distal contact adjusting tool. That is set up to the proximal contact parameter, which is -25. Now, in my clinical theater, with the way I have my milling units calibrated, I use -25 because I don't use fast mill. So I know in my finishing procedure protocol, that's going to work really well for me. Just thought I'd point that out. Some of my colleagues say they need to use green, and some even say they have to go yellow. Well, it depends on how you want to finish. It doesn't matter as long as you're getting your results and paying attention to the system you have. So in general, I'll get the size of the interproximal contact I want, and if there's colors other than aqua that are stronger, like yellow or green, I'll hit the contact adjusting tool. It's an effective way to move through that. And then we can use either the removal or smooth tool if we want to smooth that contact out. And then the last thing I do before I go to the mill screen is check the emergence. In most cases, unless the tooth is rotated, the emergence with the current software is pretty nice, particularly with biogeneric individual. I don't have to touch it a lot. I'm going to look for minimal thickness issues on that margin for the mill effect, since I have a tendency to go with conservative prep margins and stronger materials. I just like that conservative approach, so that's naturally in my thinking of my workflow. Is this fun? Once we know we have this workflow accomplished in the right order, fit the arch, occlusion, proximal contact and emergence, we go to the mill screen and we enjoy the mill process. Wasn't that fun? That's my workflow, particularly with occlusion and proximal contacts. As a result, when I enter that digital theater, and particularly since I've been back, I've been doing about 50-50 of Emax and zirconia. But my workflow is very proficient, mainly because I have enough occlusion reduction, and I can't overemphasize that. So to set up occlusion, you need enough occlusion reduction so you can let the beautiful biogeneric individual morphology, which will recognize the adjacent teeth and the opposing arch, and give you a really nice proposal. If we need to use our tools to pull up that occlusal table because the minimal thickness is not being reached, which is always your minimal thickness is going to be minus your spacer. So the software now sets up that in our parameters. We can't preset our parameters for minimal thickness for materials anymore because that's recognized within the software. So if you do need to recalibrate your parameters, you do that in your design screen on the step menu. But that's pretty much my workflow. I do enjoy CAD/CAM mainly for that reason. It's very positive in my clinical theater. I've been practicing a long time and I do not know it all. But the one thing I do have great success with is occlusion. Now, full mouth rehab is a whole different ball game, and we'll probably do some live dental shows on that in the future. And I respect the fact that we all have different approaches to this. This is the one that I've come to. This is where I'm at after 37 years, particularly on bread and butter dentistry every day. Well, thank you for watching. I'm going to keep this a little shorter today because I know it's a holiday weekend, and I do wish you folks a great holiday weekend. You know, last week I laid my mother to rest, and I actually feel at peace with that because she had Alzheimer, and that was a hard thing to watch her go downhill with. And, you know, life is made up of joy. Life is made up of sorrow. And that's just defines our love. You know, when you miss someone so much, you see how much you love them. And my challenge to us all today is really love the ones that are in our life. Even love the unlovable, right? I always say that when I'm dealing with a difficult client, is love the unlovable, because they're pointing out things in us that bug us, which we have to look at. So we're never owned by someone else's emotional projection, which is a hard thing to do. I don't have that mastered yet by any means. But I do think of my mother, of how kind she was to people all the time, even the people that didn't treat her well. She really, which were very few because she was so well liked, but she was always kind to people. And I think of this country of ours, and I'm so grateful I live in the United States, even though there's other countries that are great, and we have people from other countries watching this webcast, and I celebrate your joy of your country as well. But my grandparents came over as immigrants, and my father taught us how to work hard with good perseverance and work hard at what we do. And I'm really grateful I was able to go through dental school and do what I do today and have a lot of control over my destiny. Though the COVID situation kind of challenged that because we couldn't work. but you find ways to pivot, you find ways to get around it. And I really want to be grateful for our country. Our country is not perfect. No country has ever been perfect. No family is perfect. But the whole thing that makes us work together is the essence of forgiveness, right? If you can forgive the ones that hurt you, you're going to have a better life, because that way you don't harbor the bitterness, and you can treat others with respect regardless of how they treat you. And that's something my mother taught me. I don't mean to be preaching right now, but it is a solemn time to lose a parent, but yet it's a joyous time to live and be the best we can with what we have. So next week, my buddy Todd's going to be back with us. We got to get him off that bike. And we will post this next week, what our topic is going to be. Now that we're all getting back to work, this dental show is going to be more around clinical applications of products. We'll keep interviewing people, clinical applications. Both Todd and I are educators within the CEREC world. I love what I do in my CAD/CAM world because it really helps me to be a better dentist, and we want to pass that on to you because we love what we do. So have a great 4th of July weekend as you finish this time out, and you have a great week, and we're looking forward to seeing Todd next week. So you take care of yourself and you be safe now. Okay? Bye.